don't require an introduction, but is Tonya Kaltenbach joining us here from the city. And many of you know Tonya from her earlier times at Stanford at the Palo Alto VA, her seminal work with Roy Sategno. She is now up in the city at the San Francisco VA Hospital, Associate Professor of Medicine at UCSF, and she has really been involved with almost all the important studies about colonoscopy, large polypectomy, quality in colonoscopy, advanced imaging, and she's going to give us a whirlwind summary of what's latest and greatest in colonoscopy. Thank you, Tonya.
Good morning, and thank you for inviting me to the conference. I think this is a really great conference that's organized each year, and I'm very pleased to be a part of it. I was asked to talk about the best of colonoscopy at DDW in 30 minutes, so I've tried to highlight 5 areas that I thought we could be of interest to us. And so mainly I wanted to focus on our most common area of colonoscopy, which is colorectal cancer screening. I'm going to review the current recommendations, including age for screening, identify colonoscopy quality improvement measures as we focus more on quality and insurance focuses more on quality for reimbursement, and summarize applications for artificial intelligence, which was very much a huge part of DDW this year, were many abstracts and presentations on artificial intelligence in colonoscopy. And then, of course, I will speak about endoscopic resection of benign complex colorectal lesions, mainly describe the surgical outcomes for these lesions so we understand when we send patients to surgery for benign polyp what that means compared to endoscopic resection outcomes, and then also the endoscopic resection in inflammatory bowel disease patients in lieu of colectomy. So to start a baseline, I used to give this slide and I would say 1 in 20, but now in the US it's 1 in 25 people will be diagnosed with colorectal cancer. Still a very high number, it's highly prevalent cancer. That's why we have a screening test. That's why there's a public initiative to get us screened, because it is so common. And that's why most of us in this room either have a friend or a family member who we personally know who have had colorectal cancer. The great news about our efforts in the United States is that our colorectal cancer incidence is going down. With our mass screening efforts, we're seeing declines in incidence of colorectal cancer. This is the most recent SEER statistic data available showing this decreasing trend over the past decades. But the other trend that we're seeing that has been very public, and for some people personal, has been the increase in colorectal cancer incidence in younger patients, and specifically in patients aged 40 to 49. So we're now seeing not that decreased trend that I showed you from the SEER data overall in colorectal cancer incidence. We're seeing an increased trend in more recent decade in younger patients ages 40 to 49. And this is from a letter that was recently published in JAMA. And the interesting part is it's not that we're finding them earlier. These patients are often presenting with more advanced disease as well. So this is a real issue. This isn't something that we're paying attention to, so we're finding it early. This is something that the increasing trend is real. We're seeing it across all stages of cancer, and it's garnering a lot of attention about what we should do and how we should respond as a society to this change. And so last year, the American Cancer Society actually came forth, as we all know, and said that we should consider screening starting at the age of 45. And that is certainly a new age for all patients. The American College of Gastroenterology had recommended screening age 45 for African American patients, but not for all ethnicities and genders. And so the ACS had recommended that. And the societies responded quickly because we, as Practitioners weren't sure how to respond to that. It was very public. Many patients were asking us. We weren't sure what to do. And in the ACS's statement, they even said, your insurance company may cover this, but they may not. When you're 50, your insurance company will cover it. So that puts us in a dilemma, too, because patients don't want to pay for something that is considered screening as well. So a little bit of a conundrum. And the societies came forth and said, let's wait. This recommendation was based on modeling data, so let's wait. So I'm presenting this background because there was a lot of talk at DDW, a lot of research in the past year on this topic to help guide us further to say, should we be moving towards public policy and recommendations from societies, especially US Preventive Service Task Force, that we should screen younger patients. So let's look a little bit more at the data, and this is data that was published in recent literature as well as data that was presented at DDW. So the actual US colorectal cancer burden in patients 45 to 49 years old. Half of all cancers that are diagnosed in patients under 50 are in this age group. So clearly an area to target more cancers. We'd capture the most of these younger patients if we target 45 to 49-year-olds. So there were 7,000 new colorectal cancer cases in 2017 and 1,800 deaths in this, showing, again, likely advanced stage of diagnosis. So this is a table that just shows similarities and approaching the 50 to 54-year-olds for the percentage of all colorectal cancers. And this was a cost-effectiveness analysis put forth by Yuri Lauterbach at Stanford and colleagues to show we need to know, is this cost-effective? I mean, I have many friends who are asking me, should I go get screened? Why aren't they screened? I have a personal friend who was diagnosed with metastatic colon cancer, and all of my roommates from college, she was one of them, are saying, why didn't she get screened? Why did your field fail her? And so there's a lot to try to explain about public screening versus individual health care. And so, of course, we need cost-effectiveness models for public policy. Yuri put forth this, and it's basically showing, I'll summarize it more here, but colonoscopy screening at age 45 saves 4 colorectal cancers and 2 colorectal cancer deaths per 1,000 patients screened. And from a quality of life years gain standpoint, that's what we care about in cost effectiveness. It's 33,900 per quality adjusted life year gained. So basically, it showed that if we start screening 45-year-olds, it's cost effective. But in doing so, we need to consider a stratified, organized approach to optimally control costs, because it will be very costly to screen all patients, all people in this age group. And the other side that he looked at, which is on this side, is you can see it's certainly more cost effective, and you're reaching more cancers, diagnosing more cancers, and impacting more quality adjusted life years gained in this later age group. So one of the other messages is it's more cost effective if we actually increased adherence in persons over 50 years. And if you look across the country regionally and nationally, we're reaching about 65 to 80% of colorectal cancer screening in that current age of screening. So I think we're potentially soon reaching and maximizing that, and so that may not be as much of an area we target for screening in the future, as we're doing a fairly good job at that. Still some room to go. So let's remind us, well, what should we do for screening? So certainly colonoscopy, performing screening colonoscopy is important, or performing FIT screening is important. But when we do that, we have to assess and ensure quality when we do these things. We can't just perform a colonoscopy or perform a FIT and not adhere to quality measures in that. So part of the US Multi-Society Task Force recommendations, when we put forth the screening recommendations about a year ago, was to say we need to include quality measures when we do colonoscopy, and one of those being adenoma detection rate. So various quality measures, as we all know, about cecal intubation rate, adenoma detection rate, bowel preparation, adequacy, and adenoma detection rate has been the most had the most attention, because this has been the metric that has been most associated to actual colorectal cancer incidence and death. And this study has been put forth numerous times since its publications now 5 years ago, but to show this strong correlation and strong surrogate marker for quality being ADR. But it also remarkably showed the variability in current colonoscopy performance with ADR. So you can see that range of 7 to 50% in a similar patient cohort for what an ADR is. And then you can see how that inverse association of a high ADR is protective, so less colon cancer later, interval colorectal cancer, and a low ADR, your patients are less protected. And then furthermore, Kamiński, so a Polish group, showed that if you can improve your ADR, it translated to reductions in your patient group's later development of colorectal cancer or death from colorectal cancer, to say this isn't just a one-time. If you actually made improvements in your ADR, you were then, it was resulting in further protection for your patients. So how do we, let's see if this will play. Sorry, just one. Could you play the video? Great. So how do we actually inspect, or how do we perform a quality exam? Certainly technique, inspection technique, adequate bowel preparation, inspection behind folds, time. There's many different variables involved with high quality inspection technique, of which ADR is the ultimate outcome today. And how do we not miss things? So how are we able to see something really subtle and with our technique, number one, appreciate it, and then number two, interpret it, so that later this patient wouldn't then be going on to have an interval cancer. This very subtle, small finding that was humbling was a T1 ascending colon cancer. So you can see how small that is, but this patient would have certainly had an interval cancer if that had not been detected. So I show that background as well because at DDW there were many presentations, I'm going to show two, to show us, well, how can we improve and sustain ADR to maintain this quality? So one was put forth about individualized feedback on colonoscopy skills improves group colonoscopy quality in providers with lower ADR. So a lot of feedback has been shown to be important. This specific feedback was about colonoscopy inspection quality, and so that fold examination, the cleaning, the luminal extension, doctors, there were 16 colonoscopists from a single academic center who received standardized feedback, and this feedback essentially was ADR, serrated polyp detection rate, and withdrawal time. And then they had all of their colonoscopies video recorded, and then 7 of the colonoscopies were graded using this scale that I showed you, which is this quality inspection scale, colonoscopy inspection scale, excuse me. And so then these colonoscopy inspection quality scores were used to create individualized report cards and in videos. So they got feedback as well as videos to show them the different aspects of colonoscopy quality. And then in 12 months' time, compared the ADR, SDR, and withdrawal time in the group that received this compared to the group that did not. Compared to compared it, to pre and post report card. And so this is an example of report cards that a provider would receive. So it shows their cleaning score, their distension score, their total score, and it gives them the ratings and where they were in terms of their percentile with their cohort. And then they actually had links within these report cards to videos about the different examples of poor to excellent within the different domains of quality and of colonoscopy inspection. And so in looking at that, the group before the report card, the group they split it at less than 33% ADR being low performers and greater than 33% being high performers. And you can see here that the greater than 33% baseline ADR group did not benefit significantly from such an intervention, but that the lower ADR, and low ADR in this case, again, is 33%, and our national benchmark gives us 30% as a threshold. So even at less than 33% performance, they had significant improvements in their ADR. And you can say, well, this is a 3% improvement. If we remember from the Doug Corley study, every 1% increase in ADR results in a 3% reduction in colorectal cancer incidence and a 5% reduction in colorectal cancer deaths. So these small changes are big impacts. So another group from Doug Corley's group showed a similar, that if you give feedback with training, that you can increase ADR as well as reduce colorectal cancer incidence. And so Doug looked at actually specific behaviors of why we don't perform well. And so there was lots of things, behavioral variables that may influence your performance in detecting polyps. He focused on 3 of these sort of behaviors, being beliefs about polyps, the exam technique, and the flat, subtle polyps. And basically, this was a single-arm study. It was an online interactive training, and these 86 gastroenterologists received ADR feedback, and all of them watched this training. So it was at different centers. It was at 20 medical centers, and their chiefs basically advised them to watch this training, and then the chief gave them feedback. And basically, after these sessions and feedback, they measured changes in their ADR, and this was in 2014 when this happened, so then they measured interval colorectal cancer. And you can see here from this table that was submitted in their abstract that of these endoscopists, if you look at the quartiles here, there were of interval cancer, if you look at this for the ADRs, you can see that the low quartile decreased and the high quartile increased. So ADRs increased over time after these interventions. And more importantly, when we want more hard outcomes, you can see that there were reductions in colorectal cancer incidence based on increases in ADR. So an increase in maintained high ADR had a 42% reduction in interval colorectal cancer. So these are great, and there's been so much talk about how we can improve our technical performance over time, whether it be technology, whether it be technique, whether it be nurses, fellows. There's so many studies on ADR improvement, but can someone else help us, meaning a computer? And I think there's been a lot of attention to that from industry, from academic investigators on this. And certainly in our world, we use AI often, and we have a smartphone. There's facial recognition everywhere. We use that on our phones to find photos even. So why can't we do this in endoscopy? It could be applied to so many areas. Provide us information on insertion, on how we're handling the scope, on the ergonomics of that, if we should readjust. Certainly on cecal intubation documentation, how we're inspecting. Instead of taking a video in real time, we could get feedback of where we should inspect and what surface area we missed, helping us find lesions in real time and tell us what they are, if it's something we need to care about or something we don't, something we need to resect or something we need to send to a surgeon or send to another endoscopist. If we completely remove a polyp, so giving us feedback on polyp residual in real time, telling us about a competency assessment, so giving us real-time feedback if we're good or not, objectively, not just subjective feedback, based on specific parameters, and giving us feedback on our instruments or tools, and then ultimately, which would really help efficiency, is if it could help us generate reports, so that would be helpful. So there's so many areas in our endoscopy where AI or artificial intelligence could help us. So the most presented, I think, and the closest at hand is in polyp detection and in polyp characterization. And so if you could start the video, please. Is it bright enough? Yeah. So this is just a case where we're withdrawing. In this video, they're withdrawing, and you can see polyp. And then you can see in the upper left, it's just sort of giving you this, hey, lighting up and telling you that there is a polyp there. So that was early, some early software development in that. There's been publications on that in addition to all the presentations at DDW, but there was a publication in Gastro just earlier this year or last year showing again the value and the reality where we can use these softwares during real-time colonoscopy to help us find polyps. Here's an example. It circles it for you as a primer. If you could play this video, thank you. So here's another example where a polyp is found, and in this case, it's diagnosing it for us. So is that a hyperplastic polyp or type 1 nice, or is that a adenoma? So the first one was a hyperplastic, and now it's showing us here in narrowband imaging this diminutive lesion, and on the left there you can see it's giving us information about what this is, and that's telling us it's a nice type 2, so there's probability or giving us confidence that this is an adenoma and we should remove it. Here's just another example of that. So there's the polyp at 6 o'clock, and then using narrowband imaging and with the NICE classification telling us that that's an adenoma, giving us confidence as the endoscopist that we should be removing this, as opposed to if it was, say, hyperplastic or not. So this has been developed very much sort of modularly and has been shown from different centers, the value of it. This was a publication about using it for classification, like I showed, between differentiating adenomas from hyperplastic. And you can see compared to experts, and that the computer-aided diagnosis does a really good job in terms of its diagnostic operating performance and characteristics. So, and certainly more importantly, it does it faster. So in terms of improving endoscopist confidence and efficiency and helping us in making management decisions. So at DDW, one of the things that was presented was sort of a combination, because certainly we're mainly interested in detecting polyps, and then after we detect them, we want some guidance in what we should do. So this group basically combined detection and diagnosis in one. So if you could play the video, please. This is in the detection mode. It's the last one. This one, please. It's not playing. Oh. Okay. Well, as you could imagine, it's essentially the detection part and the diagnosis part together. So a circle or a square will light up on the screen as you're withdrawing to help you find the polyp, and then as you get closer and use diagnosis tools, oh, thank you, then you can characterize it. So you can see the square there lighting up on the screen. Now we get closer. And you can see in this case sort of the endoscopist is all over the place and it's still finding it. So it doesn't need to be like a steady hands for it to work. And then this is showing likely in the rectosigmoid area these multiple polyps that it's showing you, and then would do the characterization. So now telling you this is a type 1 hyperplastic. Inspecting this, another type 1, you can see it's pale, lacy vessels, uniform pattern, classic type 1 hyperplastic. And you would have high confidence in that, and your confidence could be increased with potentially computer-aided diagnoses and detection diagnosis tools. So that sort of talks about colonoscopy and detection and diagnosis and what we should do and focus on quality measures. I wanted to spend the last few minutes focusing on removal of polyps. And so this is an area that I have great interest in, and that we do a lot of research in, and I do my clinical practice mainly at the VA and at UCSF in removing polyps. And so the endoscopic resection of complex lesions has been safe and effective. We know that. But the majority of polyps, actually 2 centimeters or larger, are surgically resected. And the incidence or the trend of surgical resection for benign polyps is increasing. And that's because we're doing more and more colonoscopies, and colorectal cancer is going down, and colectomy for colon cancer is going down because colon cancer is, but colectomy for benign lesions is increasing. And that's really something that shouldn't be the trend, because we have outcomes data to show that as gastroenterologists, as endoscopists, we can remove these safe and effectively. And so despite surgical costs being 5 times higher than endoscopic resection costs, and despite morbidity and mortality being higher with surgical resection compared to endoscopic resection, that's still the trend. And that's because of our training isn't there, our reimbursement isn't there. There's no incentive for us in the field to remove these difficult and challenging polyps. It takes longer time, takes more resources, and there's really a lack of reimbursement. So there are certainly obvious barriers there that could be addressed, but it still doesn't mean from a patient what we should do right for the patient we're not doing by having these patients undergo surgery for benign polyps. So this is, in the last year, there's been 3 or so publications informing us of what happens to our patients when we send them to surgery for benign polyp colectomy. And it's interestingly, they have a 1%, close to 1% chance of dying from that surgery. So this is a patient without a cancer who's having a lesion removed, and 1 in 100 of them will die from that procedure. And then the complication rate or the morbidity was about 20% in terms of leaks, readmissions, et cetera. So this should make us pause, because when you send your patient for an alternative management plan, you want to make sure that that's the safest and most appropriate one. And the other side of it is that we have endoscopic resection that doesn't have a 1% mortality and doesn't have a 20% complication rate of admissions and hospital stays and resurgery. So I think that this is something that as gastroenterologists in the field we need to sort of really take ownership of and change this practice of surgery. And I think that California, I do a lot of outcomes research, and one of it has been trends in EMR. And I'm probably speaking to the wrong group, because the West Coast is the outlier of whether it be Northern California, Southern California, Central, is that we're doing EMR for polyps. If you live in the southern region of the United States, the trend is much more for surgery. I'm not saying that there aren't any surgeries done in this area for benign polyps, but we look like we're taking this initiative and sort of owning it and moving forward. So there are regional trends in the practices of the management of these polyps. So another field of this, another area of this is IBD. So historically, any patient who had inflammatory bowel disease with a polyp was referred for a colectomy. And in 2015, we had an international consensus of the CNIC group to visit this management strategy. With now us understanding lesions and us being able to remove them, should a polyp in a patient with IBD automatically warrant a colectomy? And so there wasn't a lot of data that we could find on flat lesions, which is the majority of lesions that IBD patients have. So my group actually, and we presented this at DDW in an oral, so I'm going to share this with you today, the longitudinal outcomes of the endoscopic resection of flat non-polypoid dysplastic lesions in patients with IBD. And I've given you the background to say that, that patients with IBD do have a higher risk to develop colon cancer, and we do surveillance in these patients, and that currently, from at least the CNIC guidelines, we recommended when we find these lesions that they should be endoscopically resected, but it was a suggestion and a low quality evidence suggestion, so it was a conditional recommendation because the evidence really wasn't that strong. So this is an example of one of the lesions we find in patients with IBD. It's tough. The colon's scarred, it's flat, it's subtle enough to find, let alone for us to remove. But when we had a patient advocate in our scenic international consensus, they want to keep their colon. Most patients don't want their colon removed. I mean, some of them need it removed, but most of the patients say, if you can just give me a few more years or 10 more years, they want their colon. So, but a lot of times that isn't the option, and they go on to have their whole colon removed because of that small lesion that was found. So what if we can remove this endoscopically? And so in the last decade, we have availability from an endoscopic standpoint to do such. So we have tools now, whether it be endoscopic submucosal dissection knives or different snares. And the companies have also been very interested and have developed their tool platform much more and expanded it, whether it be injection being more viscous and helping us in these tools to help us now where we can remove such lesions and then save the patient from a surgery. So that's an example of an endoscopic submucosal dissection for such a lesion. So we looked, and this is just a quick image of the different steps so you can appreciate it. So again, scenic, when we did this, we said after complete removal of an endoscopically resectable non-polypoid dysplastic lesion, you should have surveillance colonoscopy as you would after other polyps rather than a colectomy. And so we looked at basically asking, is it safe and effective? What are the long-term outcomes of these patients who undergo endoscopic resection instead of colectomy? These are my final slides. So, yeah. And so essentially, we looked at 10 years of data at 2 VAs. So I was at San Francisco VA, and we practiced this there for the last decade. And we were close collaborators with San Francisco VA, and that's where I am now. So we looked at the past 10 years of data, consecutive patients with IBD who had colonoscopy. And in this group of patients, we identified the ones who had a flat, non-polypoid lesion that was 1 centimeter or larger. And that classification was based on the Paris modified from scenic, what a non-polypoid polyp would be. And then we used our techniques, whether it be EMR, ESD, or hybrid ESD, where we free up the lesion where we can then snare it, because these patients often have a lot of scarring. And then we used endoscopic principles to remove them. So essentially, if we couldn't see the border, that's not eligible. And certainly, we didn't just do biopsies on biopsies. So we did EMR, ESD, or a hybrid of EMR, ESD. And even simple polypectomy can sometimes work, but the majority of patients with IBD, with even such a small lesion here, you couldn't remove it because of the scarring. It's stuck down. So this is just an example where simple polypectomy often doesn't even work. And even when we do dynamic injection, which is the injection technique that we described to help mold flat polyps into polypoid polyps, when you inject by moving the needle catheter and creating that bleb nicely, you think you have a beautiful bleb here, and then you'll see that it can sometimes work, and then sometimes in IBD patients it just dissipates because there's just no space in the submucosa with all the scarring. So this is just an example where you think it's lifting, you're doing the dynamic injection technique, looking up, suctioning, pulling your needle catheter back, and then you'll see that after injecting, I'm just suctioning, this is Roy's Satikno's case here that I'm showing, that it just sort of dissipates, and it's going to be hard to get a snare around that again. So all this fibrosis sometimes requires us to use a knife to separate the mucosa from the submucosa. And so using these techniques and this approach, there were 326 patients that were followed, and 161 lesions, 1 centimeter or more, were identified. And ultimately, there were 63 of those were non-polypoid, so flat lesions in 36 patients. This was an average risk IBD group, meaning they did have pancolitis, but few of them had a history of colorectal cancer or a family history of colorectal cancer, and only one had PSC. So these are what the different lesions looked like. And this is their distribution. So they were sort of all throughout the colon, and the majority of them were tubular adenomas, which is important. A lot of these patients have low-grade dysplasia that then go on to colectomy. And we were successful in removing 97% of these lesions, and the majority of them we removed with EMR or ESD, and the majority of them were removed en bloc. So there was one delayed bleeding, there was no perforation, and there's, importantly, which was my most interest in following this patient cohort, was did anyone get an interval cancer, which is why they're having a colectomy to prevent cancer. So there were no interval colorectal cancers in this group. We followed for 1,200 patient years with 14-month median follow-up time. And in our lesions that we did remove, there was a 6% local recurrence, but we treated all those endoscopically. So whenever we talk about local recurrence in whether it be non-colitic or colitics, we're talking about adenomas. We're not talking about cancerous recurrence, and most of them are diminutive or small. So I think that this is just, I won't go through all of these for the purposes of time because I feel like I've shown you, but in summary, our IBD cohort showed safe and effective application of endoscopic resection for their lesions in lieu of surgery. And so from my DDW update, the overall summary I'll share with you is that increasing incidence, still currently only an ACS recommendation, but I anticipate there will be recommendations from societies and in the near future. An engagement and quality improvement program with training and feedback is associated with improvements in ADR and reductions in interval colorectal cancer, so I would encourage us all to engage in a quality improvement program. Artificial intelligence facilitates colonoscopy lesion detection and characterization. I think that this will become available to us also in the near future as incorporated into our endoscopy rooms, and that endoscopic resection is first-line strategy for the therapy of benign colorectal lesions. The surgical morbidity and mortality is significantly higher compared to endoscopic resection, and that colonoscopy surveillance in lieu of colectomy is safe and effective in IBD patients with flat lesions who've had them completely removed. Thank you.